Good morning and welcome to today's webinar, Promoting Professional Accountability and a Culture of Safety and Respect. I'm Millie Mastromati with Optima Healthcare Insurance Services, and I'm your program moderator today. Today's presentation will discuss what we can do when a clinician models behavior and performance that undermine the best attempts to create a safe and reliable healthcare environment. Our speaker will talk about addressing this challenge with the right people, processes, and data to promote early identification and effective peer-based interventions. We have lots of opportunities for you to share your insight and opinions through polling and a new technology called Word Cloud. So I appreciate your participation in advance, and let's just hope that the gods of technology are with me as I learn this new opportunity. I'll be monitoring that chat box for any of your questions. We'll probably address them as we can during the presentation. I'll give Dr. Webb a heads up if a question comes in. And speaking of Dr. Webb, he is our speaker today. Dr. Lynn Webb is the Assistant Dean for Vanderbilt School of Medicine and Assistant Professor of Medical Education and Administration at Vanderbilt University Medical Center. Dr. Webb serves on the faculty of Vanderbilt Center for Patient and Professional Advocacy and leads the center's coworker observation reporting system. Welcome, Dr. Webb. It's great to have you with us today.
Well, Millie, thank you very much. And thank you, everybody, for joining today. As Millie said, we're going to talk about impacting culture, primarily associated with professional accountability of physicians and advanced practice professionals and others. Our mission at our Center for Patient and Professional Advocacy at Vanderbilt is really to help make healthcare safer, more reliable, more compassionate, primarily by talking about and focusing on the behavior of professionals. And as Millie said, please chat a question if you need to, and we'll certainly have time for some questions also during the presentation. Vanderbilt just asked me to remind everybody on the webinar that this information and some of the data belong to Vanderbilt, and I know you appreciate that. So we work with about 200 hospitals across the country on enhancing a culture of safety, and many in California, including Stanford and all the University of California schools, Palo Alto Medical Group, Long Beach Memorial, University of Southern California, Keck Medicine, so I'm out in California quite a bit doing this work. We know that all of those institutions, including the ones with which you're affiliated, are trying to become higher reliability organizations. And what we found in order to do that there are some key components that help that at any organization. One is, does the organization have, and do they let people know that there's a vision and goal and core values? At Vanderbilt, we have something called the Credo, which are the 6 main statements of how we interact with each other. At Vanderbilt, I have the responsibility to review reports every morning associated with unprofessional conduct. And about 25% of those reports, when the reporter describes what he or she witnessed or experienced, they actually say what I witnessed was inconsistent with our Credo. Similarly, Optima has a mission statement, and in essence of Credo, when they basically say that the company maintains a visible distinction of integrity and quality and differentiates through its culture, its ownership, and its results. So all of us, including your organizations, I'm sure, have a mission, vision, and some value statements. So those are important. We also find that it's very important that leaders model that Credo and those values, and also use their influence and authority when there are times when others maybe need some help in modeling those values. And perhaps most importantly, in order to have a high reliability organization and reduced risk, for example, the culture needs to be one where patients, family members, and colleagues, first of all, feel safe when they observe something that they think is inconsistent with the Credo or unsafe, and even more importantly, that they trust if something is brought up that they trust the organization is going to do something about it. We began this work at Vanderbilt many years ago, and over the years, we've actually looked at this balance beam of trying to pursue high reliability organization. On the left, intentionally designed systems. All of you probably are members of a quality improvement project team, constantly trying to improve your systems. What we found over the years, though, that an organization can have the best darn systems possible or continue to try to improve them, but if professionals don't appear accountable to those systems, it still may compromise quality and safety. We got into this work about 20 years ago by Dr. Jerry Hickson and others, looking at why do patients and family members decide to sue hospitals and physicians and other advanced practice professionals. And what we learned from interviewing almost 1,000 patients who have actually filed suit in Alabama and Florida was that yes, at times patients do experience less than optimal technical cognitive competence. In other words, an error may have taken place, or other competency issues. But what we found in our interviews of those patients and family members is that patients are often motivated when we haven't met their expectations in these other areas that they expect professionals to demonstrate. Was the individual respectful to me? Was he or she an effective communicator? Were they available when I thought that they should be available? Was the team effective? Was the professional even aware of how his or her words affected others? And so patients, family members, colleagues often tell an organization when they feel that professionals are not living up to these other important expectations of professionals. The good news is from our research and the research of others, that professionals tend to self-correct. If you give meaningful feedback to a physician or nurse practitioner or pharmacist or nutritionist or others, that most professionals will reflect on that feedback and actually self-correct. And that's really been a principle of how what we've tried to do to help hospitals and other organizations to change the performance of certain professionals. So let's review a case, and as Millie said, we're going to use the polling device here that's part of this webinar software. And here's the case I want to start with. This would be a case that was reported through your event reporting system, as all hospitals have. And here's the details. We were gathered at the nurse's station when Dr. X appeared to have a heated conversation with the nurse. Dr. X said in a very loud voice, "Did you go to medical school? Last time I checked, RN doesn't equal MD, just do as I say." So with that as the event, first question, do you think this is a threat to safety? You can see the options of absolutely, probably, not sure, probably not, absolutely not. So I'm just going to take a moment and have those of you who are in attendance and have access to this particular screen, please let us know, is this as described, RN doesn't equal MD, just do as I say, is this a threat to safety? All right, you can continue to give your opinion on this, but I would say we're not getting much variance of opinion on this one, that if there's an interaction that appears to be condescending or disrespectful, that may, in fact, lead in a possible threat to safety. So I'm going to go then. Gosh, we have over 20. Thank you for that. So let's go, Millie, let's go then to the next polling question after that. So if this report came through your event reporting system at your respective organization, Well, let me just ask you this. What % of the time do you think someone would actually report this in your event reporting system? So this came through someone's event reporting system. And I'll just let you know, we don't have to make any of these up. We just read them from Vanderbilt or someplace else. What % of the time in your organization do you think someone would actually take the time to report that event? Gosh, many of you are responding. Thank you very much. So let me just point out a little dissonance that I'm sensing here in these first two questions. First of all, virtually 100% of you said that this might be a threat to safety, therefore might compromise patient care in some way, either now or in the future. But looks like about 40, 50, 60, almost 70% of you say that in the organization you represent, there's less than a 50% chance that this may actually be reported. So as you're trying to become a high reliability organization, you can sense this idea that yes, colleagues do observe certain situations, but for some reason these often don't get reported. So Millie, what's the next question? If you will go ahead and go to the next polling question. Let's just say that in your organization, and it looks like that maybe sometimes these weren't always reported, in your organization, if this was reported through your event reporting system, what would be the % of the time that a medical leader might actually, or anybody, might have a conversation with Dr. X about this particular event? So you can see, based on these results already, that we have some opportunities here in most of our organizations. Colleagues observe or witness something that may be inconsistent with the culture of safety. Colleagues are somewhat reluctant to report, and even if reported, there appears to be some reluctance to intervene in some way to share that event with the person associated with the report. Now, Millie, let's go back to the slideshow. Thank you very much. And Millie, just I'm unable. Oh, there we go. Yep, good. We're good now.
I was advancing the slides. Are you able to advance your slides?
Let me just see if you're doing that or me. No,
okay.
For some reason you're advancing my slides now. So let's just stay on this one right now. So basically, what are behaviors that undermine a culture of safety? Vanderbilt has a fairly liberal, broad definition of these kind of behaviors, and I'll just name a couple. Certainly, situations where some professional creates an intimidating or hostile or offensive work environment. I was just speaking to a group of operating room nurses in Nashville. I asked them to complete this sentence. He's a great surgeon. And the next word that everybody said was but. He's a great surgeon, but you just have to deal with the throwing, or you just have to deal with the yelling, but he's a great surgeon. So it can be the spitting, cussing, throwing professional. However, it also could be the professional who tends to not pay any attention to policies. We had a situation, I'll say, at Vanderbilt where our GI surgical group was trying to improve its post-surgical complication rate for certain GI procedures, and so they, of course, researched the literature, determined best practice, taught everybody best practice, came up with a bundle that 100% of the professionals involved signed off on. And one of the part of the bundle was that at certain times in certain procedures, everybody in the OR would change gowns and gloves. So we then got a occurrence report after everybody agreed. The report was, I announced per our agreement that everybody would change gowns and gloves, and the surgeon basically said, you know, I don't really believe in that part of the bundle, so I'm not doing it. So didn't throw anything, didn't spit, but just basically said, thanks, but no thanks, even though we agreed to it. Certainly, any kind of threat to safety would be behavior that undermines the culture of safety. But overall, if really there's anything in the environment that interferes with the ability to achieve the intended outcomes for a particular team, that might be a behavior that undermines the culture of safety. Next slide, please. And next one. And also, I would just say it could be common things. It doesn't have to be outrageous things. It could be professionals not practicing hand hygiene or completing handoffs as desired, or answering pages, using best practice protocols, maybe jousting in meetings about another service. Anything basically that is inconsistent with the core values of the organization could be a threat to safety. Next slide. So, Millie, let's go to the next polling.
Okay, I'm going to pull up a word cloud, which is going to make a fun picture of your responses here. So, and you can slide down, you can kind of adjust that. But go ahead, Dr. Webb.
So basically, what the question I would like for you to ask in one or two words, just one word or two words, why might not someone speak up or report in your organization? Why not report? We're all trying to be best practice, high reliability organizations. So why might someone not report? Okay, we're getting several good words there that I can see. As I understand that this word cloud works, the more times someone mentions a certain word, the larger the word is. So you can see a big word right in the middle, potential fear of retaliation, power differentials, I'm scared to do it, there's an imbalance. I see the word previously. It could be previously I did this, but it didn't turn out very well for me. I feel that it might be intimidated. And it could just be what we find sometimes, that the team members just feel as though if I bring this out, that the team may not think I'm a team player. So being fearful, afraid, fear of retaliation, these are common things that we hear. And so the key question on this is, how can an organization, as I said earlier, to become a high reliability organization, how is it that they can support a culture where individuals feel safe to report without fear of retaliation, and secondly, feel as though that if they take the time and the courage to have the courage to report, will the organization address these issues? So good inaction, because I see inaction or lack thereof. The last thing we want is, well, Dr. Webb has been like this for 10 years. He's been reported, and so it's obvious that Vanderbilt's not going to do anything about that. Therefore, there's no use to report. So we can see and just sense in your organization the resistance, the barriers that there are. Millie, let's go to the next question. So plenty of reasons why someone might report: competing priorities, not sure how to do this. Even the leaders may blink. I fear if I speak up or report that I'm going to antagonize that individual or the team, or I'm just afraid that this person can't change. Next slide.
Okay, I'm going to pull up the next word cloud question. Give me a second to type it in. Here we go.
And so it's similar, I believe, yes, there it is. Okay, so next word cloud, even if reported, why might a leader not address the issue? So we have a clear perception on the part of a staff member. Oh, there's a big word called money. Just saw that come up. Yes, we rely upon this person. It's not an easy conversation to have. There certainly may be politics even in healthcare organizations. It can appear to be confrontational for sure. And so excellent examples of why even a leader might do this. Millie, let's go right to the next. There's one more word cloud. Let's go right to it.
Okay, let me type it in here real quick.
I believe the word cloud is why do something. That's the one I'm interested in. So why do something? Okay.
All right. So let me put you in a discussion here. There you go.
So finally, put in a word of why is all this important? Why should the organization do something? I love the way these word clouds have different configurations here. So absolutely, we are all about patient safety. That's why we're here, to make sure that every patient, every time, gets the right kind of both service and quality. It's the right thing to do. We have to have professionals who are accountable. There will be morale issues if staff do not feel that this culture is consistent with what the values of the organization are. It's all about the patient. The patient and the patient safety are right in the middle of this. So this is why this work is certainly critical to the process. Thank you, Millie. I think I'm going to go back to the slide presentation now. And let's go to, so finally, just in this balance beam of why do nothing, why do something, satisfaction, reputation, safety, liability and risk issues. I'm convinced more and more as I've done this work that sometimes employees and colleagues make this decision right on the spot. I just observed something. Is it better for me to say something, or is it more potential of fear to not say something? And I think this actually often is a minute-by-minute decision by colleagues. Next slide, please. So all of you have certain surveillance tools that are important in trying to determine what is the culture, what are patients and others telling us about our culture, our service, our quality. And we actually here at Vanderbilt focus on two primary things: patient complaints and coworker observations, what patients and family tell us about the culture and about the culture of safety and what coworkers say. So I'm going to focus, I believe, on coworkers first. Next slide. So we call this system that we've developed and used at Vanderbilt for many years and have helped other hospitals do this, the coworker observation reporting system. Here are just three from, I would guess these are all from Vanderbilt. Dr. X held the orders in front of my face, pointed to what she needed, and walked away very disrespectful. Dr. Y became angry, said, "You people are mismanaging my patients," and said all this in front of the patients and other staff. I paged the covering physician to get an order. Dr. Z listened and said, "Never wake me up for these requests again," and hung up without giving the order. So these are not necessarily outrageous or egregious, but certainly times where staff members and colleagues perceive that the behavior was inconsistent with the organization's values. At Vanderbilt, we get about 20 a week. We have close to 4,000 physicians and 17,000 staff. We get about 20 a week, not a lot, about 10 associated with physicians, about 10 associated with nurses and other staff Next slide, please. So the process that we have implemented at Vanderbilt and helped other hospitals and organizations implement is what we call this professionalism pyramid. It starts out at the bottom, the yellow part would be, why shouldn't we give a professional feedback about any concern that's raised? Now, often you see that that little word merit in there is the question, oh, does it have merit? Is it a valid concern? Do I need to investigate this concern and talk to the reporter and talk to the professional involved and try to determine who's right and who's wrong? After years of experience, our notion is it is hard to get to the truth on these because one person thinks one thing and another person thinks another. And so we essentially, unless the report appears to be egregious or has some mandated investigatory requirement, such as sexual boundary issue, hostile work environment, substance abuse, other kinds of potentially egregious nature, our notion is don't take the time to investigate this, share this as soon as possible with the individual involved. Now, however, in order for the organization to feel as though that the leaders in the organization support this effort, the pyramid goes up. So if there's a pattern, then again, we would say, why not let the individual know that he or she appears to have a pattern of these events? And then this is where it gets tough for leaders sometimes. What if the pattern persists? What if Lynn Webb has cup of coffee number 2, cup of coffee number 3, appears to have a pattern? We let him or her know that behavior needs to change, but no change. Then it's the organization. What is the organization going to do about it if the pattern persists? And essentially, at that point, we think it's necessary for there to be a plan developed. Now, I would just point out, before that level 2, the apparent pattern, single concern at Vanderbilt and all of our other organizations we work with, these conversations are from peers, not leaders, because the evidence in the literature is that peers are highly influential with other peers on changing performance. And so we generally train peers, either nurse practitioners for nurse practitioners, PAs for PAs, physicians for physicians, who will have those kinds of conversations. But if the pattern persists, then we would want to get a leader involved. Next slide, please. As I said, the lowest level, we call these things informal cups of coffee conversation. Next slide. And what are those conversations? What are the attributes of that conversation? Well, if you were on the receiving end of a cup of coffee conversation, hopefully you would want the conversation to be non-judgmental, highly respectful. I'm not trying to direct you for anything. I am just trying to report an event. And so we train our peer messengers that if the person says that didn't happen that way at all, or anything that's inconsistent with what the report is, we train our messengers to say, I wasn't there, because the sole purpose, if you go to the next slide, of a cup of coffee conversation is just simply to let the individual know that an observation that was inconsistent with the values was observed, and just let them know that. If a colleague accomplishes that goal, then they've accomplished the purpose of the feedback. It's not trying to fix the person, not trying to make the person feel guilty, not trying to tell them what to do, just simply sharing an event. Messengers tell us that these cup of coffee conversations last about 3 or 4 minutes. They're not very long. And I'm using this as an example of an organization who monitors their event reporting system and then trains some peers to share those. But certainly the best sharing is when people speak up on their own. They simply speak up and say, Dr. Lynn, Millie, you're a good colleague, and I just observed before you went into that room that you forgot to wash your hands or use foam, and so I'm just making you aware of that. Thanks, have a good day. And if Millie says, well, I did too do that, then the colleague says, okay, I just may have missed it. I just want to let you know. And sometimes colleagues can get very defensive about it, But generally what we find is, regardless of the defensive nature of the conversation, most colleagues will self-correct. So anyone can do this. We think it's better for every single non-egregious event to be shared as soon as possible. At Vanderbilt, these come in overnight. We read them, make sure that we know the attribution is clear, that it's really a report of unprofessional behavior. And by about 2 o'clock the afternoon after this happened, we will have this to a trained messenger to just share the event with the professional. There's no record of the sharing. It's just we want to make sure it gets shared. It doesn't go into the personnel file or anything like that. Millie, next slide, please. Let me ask you just, Millie, I'm going to actually, because of time, I'm actually going to, well, no, let's do this one. So here's another scenario. Dr. S came into the nurse's station and took my pack of crackers. This was a reported event. We don't make these up. I said, those are mine, and he just looked at me, turned, and walked off. So another polling question, is this a threat to safety? Took my pack of crackers. So some divergent views here, but not too much, is that most of you would say, come on, Lynn, took my pack of crackers. So I might say, well, so why might someone think this is not a threat to safety? Well, no one was harmed. Maybe the nurse was too sensitive. Maybe the professional was hungry. So probably not any harm to patients. But then someone else might say, well, wait a minute, this kind of interaction between two professionals might in fact impact future communication, which then might impact safety for a particular patient. And interestingly, for this particular event, this was the first reported event for a physician who eventually had more reports of unprofessional behavior than anybody else that ever was at Vanderbilt, and eventually left the organization. So we just never know what the pattern's going to look like, especially if we don't hear from that first event. And the good news is that most of you are saying, well, if this is reported, certainly it would be good to share that with the event, with the professional involved. Okay, Millie, let's go back to the slide set and keep going. One more. There we go. So we've been doing this for about 8 years at Vanderbilt. As I said, we actually are tracking now about 29,000 physicians and advanced practice professionals across the country. And it may not surprise you to learn, and hold on just a second. I didn't move anything for a while, and my computer just went off, so hold on just a second. It may not surprise you to learn that coworker reports are not random. 3% of professionals, and this is consistent in any organization we're working with, 3% of professionals account for half the reports. About 90% of professionals don't get any reports at all. So you can have the same EMR that's frustrating to some. You can have the same admission discharge policies. You can have the same no verbal orders. You have to put your orders in yourself. 90% of professionals seem to be able to deal with that without creating unprofessional interactions. 3% of professionals get half. Next slide, please. Now, we began to wonder, well, does any of this matter? And so we just actually published in JAMA, just in February, a study that we looked at 4 institutions that we worked with. We looked at a relationship between the number of coworker reports of unprofessional behavior for surgeons and that surgeon's patient's post-surgical complication rate. And so you'll see that for surgeons who had 0 reports of unprofessional behavior, their post-surgical complication rate, which would include pneumonia, wound infection, other kind of wound problems, readmissions, the the surgical complication rate for those patients for physicians' e-reports was right at the median for that particular disease, that particular diagnosis. Patients whose surgeons had 4 or more reports in a 3-year period, those patients were 28% more likely to have a post-surgical complication. And if you would just extrapolate that to all the surgeries in the country, that's almost 600,000 additional complications per year. So what we found was it's not just about interactions, that those interactions might create the team, and in fact, not functioning as optimal as possible and may have an impact on patient care in the OR. Next slide, please. So for about 20 years, so that's coworker reports. For about 20 years, we've been looking at patient complaints. Dr. X was rude the moment I met him. I'm a person with a painful problem. Why be a jerk? Dr. Y is either too busy or scatterbrained to read my file. I fear for my safety. If Dr. Z had stressed the adverse effects of the procedure, I would have never gone through it. At Vanderbilt, we get about 6,000 patient complaints a year. And at Vanderbilt and all the organizations with which we work, we strongly advise the more patient complaints, the better. The more patient complaints, the better, because there are at least 2 studies nationally that show that for every 1 time that a patient comes to tell us about a concern that they have, that there may be somewhere between 20 and 40 who have that some concern but don't come to us. So they might put it on Facebook, they might tell friends, but they don't let us know. It is possible, we found at Vanderbilt, University of Pennsylvania published this, it is possible to improve your press Gainey scores and also increase the number of patient complaints that you have. Those 2 things are not incompatible, and we highly encourage all of you to always find ways to increase the times that you are hearing from patients. Next slide, please. So this is in part why we got into this work several years ago, was when we looked at patient complaints, and we've now replicated this study 8 times, 5% of physicians are associated with about 35% of unsolicited patient complaints, and those same 5% of physicians without intervention account for 50% of the organization's claims dollars. Keeping in mind that as many as 50% of physicians never get a single patient complaint, and those 50% account for about 4% of claims dollars. So what we found in our work, that patient complaints appear to be the best single predictor of future malpractice risk for physicians and advanced practice professionals. There are other factors. Gender is a factor. Males get sued more than females. Specialty is a factor, as you know. Some of you are risk managers. Some specialties, OB, spine, neurosurgery, seem to get sued more than other specialties. Volume is a factor, but not as much as some think. What the literature shows that if you're above the 90th percentile, you a physician, above the 90th percentile of volume, either in RVUs or patient visits, of that compared to your colleagues, your risk goes up. But the other 90% of physicians can be very, very busy, but it appears that doesn't improve, doesn't enhance, doesn't increase their future risk. So essentially, when we did the factor analysis on gender, specialty, volume, and patient complaints added for 3 times the variance among those physicians being sued than volume, gender, and specialty. And so that's why we've used patient complaints as a predictor for if a physician's practice appears to have a pattern of patient complaints, that physician is about 3 times, between 2 and 3 times at risk for future malpractice compared to his or her colleagues. Next slide, please. We initially did this post-surgical complication study, also published in JAMA Surgery in 2017. Similar results for patients whose surgeons had 0 to 4 patient complaints in a 4-year period. The median complication rate of those patients was right at the median for that patient's diagnosis group. If a patients whose surgeons had 14 to 60 complaints in a 4-year period, those patients were 21% more likely to have an additional complication. Next slide, and go ahead to the next slide. So we did an analysis at Vanderbilt and 3 other hospitals. What could be the potential cost for those additional complications? We looked in the literature, and the appearance of cost per complication was just almost $14,000. So if you extrapolate those data for those physicians who had a number of patient complaints at Vanderbilt, for example, that was an additional 635 complaints that could have been avoided if we could restore that physician to the kind of performance that everybody wants. For us, that would be almost $9 million in additional cost for those 635 complications. Next slide. So I wanted to mention one other study involving patient complaints, and look at these patient complaints that Millie's about ready to show you in the next slide. So in organizations that we work with, we occasionally get patient complaints like this. Doctor was in someone else's chart. During my appointment, he kept calling me by another name. Couldn't figure out how to turn the machine on. Nurse came in to help him. Doctor put the wrong medication on my prescription. The pharmacist caught it, but. So we looked at 4 organizations. Next slide. Penn, Stanford, Vanderbilt, and Emory, because we had 10 years of patient complaints from those organizations. Next slide. And we asked a geriatric psychiatrist and a neurologist, tell us words that patients might mention in their complaint that might be indicative of words related to impairment. And so we looked at those 10 years of patient complaints from those 4 organizations for words like forget, remembered, memory, confused, inappropriate, strange, on, uncomfortable, couldn't use, old. And sure enough, there were some physicians, those in red, compared to our control groups of age and sex and sight, compared to our control groups, there were a few physicians whose patient complaints significantly more often contain those words. Next slide. For the 4 organizations, we found 15 physicians, males 64 to 79, surgeons and non-surgeons. We went back to the organizations. Any evidence of early cognitive impairment, all 15 had been diagnosed, confirmed with early cognitive impairment, and it appeared, based on the patient complaints that we reviewed, that patients were giving us some signs that we might have been concerned about. All right, Millie, next slide. So essentially, what we try to do is to identify those 3 to 5% of physicians whose practice appears to be with high numbers of patient complaints and whose practice may be associated with high claims dollars. Next slide. We then use this same professionalism pyramid by a peer to just let the individual know that he or she appears to have a pattern. And next slide, here's some data that, the goal of this is just simply, again, to share the data in a non-confrontational, non-judgmental way and ask the person to reflect on this information. Next slide. So here's an example of the data. We may say, Millie, I want to show you some data here at, you're a physician at Vanderbilt. You can see compared to other colleagues at Vanderbilt, the bottom bar there shows that most of your colleagues at Vanderbilt have 0 patient complaints. I'm sorry, my computer keeps going off here. Hold on just a second. I need to hit something once in a while to get back. Have 0 patient complaints, therefore no risk. But for some reason, your practice appears to be associated with more complaints, therefore more risk. Next slide, please. So an orthopedic surgeon may say, Millie might be an orthopedic surgeon, and Millie may say, well, Lynn, I understand why I have more complaints. My patients are very sick. They are in pain. I may be the 5th doctor that they've seen. Sometimes I can't do surgery that they want. So it's no wonder. And so I would then say to Millie, you may be right. Orthopedists, in fact, do get more complaints. That's the blue line than physicians in general. But we track 1,253 orthopedic surgeons, and your number of complaints is number 3 out of 1,253 orthopedic surgeons. So simply all we're doing is just letting Millie know that her pattern of complaints is not only different for her own organization, but different for her specialty. And then I would give Millie all her complaints for 4 years and just ask her to read these complaints, reflect on them, and I know you'll do the right thing. Next slide, please. Now, one thing that I want to point out that's interesting, why do we look at coworker observations separate from patient complaints? Well, we were tracking at one time about 19,000 physicians associated with coworker observations, 42,000 with patient observations, and to our surprise, there was almost no overlap. For physicians who get high numbers of coworker observation reports versus high number of patient complaints, only 5.7% were on the pattern list for both patient complaints and coworker concerns. So that just told us that we really needed to look at those separately. Next slide, please. So the good news is, and we've been doing this, as I said, about 18 years at Vanderbilt and many years at about 200 other hospitals. We've identified on the patient side on the left about 2,000, a little over 2,000 clinicians who seem to have a pattern of patient complaints. 80% of that group with just that awareness evaluation by a peer showing some data, 80% reduced the number of complaints within a 2-year period to a lower than risk level. On the coworker side, we've identified about 370 across the country who appear to have a pattern of worker events. 83% of that group has not had another report in 2 years or more after having a conversation with a peer. And so this just supports the data in the literature that professionals tend to self-regulate. You give meaningful feedback for professionals, and they tend to change the performance without any other intervention, going to off-site coaching or anything else. It doesn't mean that some physicians don't need that kind of work, but most will self-correct. Next slide, please. And I would just say that if the pattern persists, this is where the organization, because from those data, there'd be 10 or 12% of individuals whose patterns persist, is that leaders are willing to step up and say, let's look at the pattern. But I'm going to skip the next polling question because I want to raise time. So just go to the next slide, please. Next slide. Now, so just put this in perspective. I don't want you to think this is an epidemic. So over all of our years, we've tracked almost 80,000 physicians on patient complaints. About half of them, as I mentioned, 43,904 have had a cup of coffee conversation about a patient complaint. Those 2,000 that appear to have a pattern, only 291 went to the next level. So essentially, this is not an epidemic. This is not looking at every single physician and saying, gosh, you have trouble with your interactions with patients or your colleagues. This really is a process to look at about 2 or 3% of those who appear to have a pattern. The data are very very similar for coworker reports. Next slide, please. So these are Vanderbilt data here. So you'll see this is over a 20-year period showing medical malpractice suits per 100 physicians. When we started this per 100 physicians, when we started this work in 2001, our malpractice suits per 100 physicians was in fact above the average for organizations, other organizations in Tennessee. That's the orange line. Gradually, we've reduced. We're about down now to about 1 suit per 100 physicians. The data actually haven't changed much across those same years for other physicians in Tennessee. Next slide. University of Pennsylvania just published this in 2018. So to the left of that vertical line were their malpractice cost cost as a percentage of operating revenue before they started identifying physicians, and they have had a 50% reduction in 2000 as of 2017 from their initial period based on implementing interventions of the type that I mentioned. Next slide. I would just say that, especially you read about this in the literature, is that there is some association now that have been found between patient complaints and coworker concerns and physician wellness. So we constantly have to also be alert to physician well-being, general health of the physician, and also work-specific stresses, because certainly this may be associated then with physician performance on professional behavior and may impact, based on the data I showed you, outcomes of care. So I just want to remind you, the goal is not punitive. The goal is to identify those clinicians that have a pattern. Some of those clinicians appear to be in need possibly of a wellness evaluation. In fact, a wellness evaluation is the most common thing we see at that persistent pattern level. Are there stresses in the clinician environment that might be affecting his or her performance? Final slide, I believe. Well, just summary. What are the impact of identifying clinicians who appear to have a pattern of behavior that are inconsistent with your values and inconsistent with the culture of safety? What happens is that if there are unreliable ways to deal with this, in other words, the CMO gets this, well, I think I just talked to Dr. Webb last week. I don't need to talk with him or her again. So sometimes there's variation in how organizations deal with physicians. I've showed you the data with regard to risk prevention and additional cost. Certainly the culture of threats, or a culture that's inconsistent with trust and safety, can affect staff turnover, can affect burnout and wellness, and certainly we want to keep our employees. So lots of reasons to look at clinician behavior in a way that, first of all, is objective, based on data, but also requires some organizational intervention. Finally, I think I have one more slide. Nope, that's it. So just that's all I have today, and I believe, let's look, we have about 9 minutes or so for questions. Millie, if you'll check the chat room, I'll be happy to answer questions either via chat or on audio.
Okay, thank you. People can chat in any questions that they have, or you can press #6 to unmute your line and ask a question over the phone if you called in. While we're waiting for something to come in, Dr. Webb, have you noticed a difference in small hospitals versus larger hospitals, and how this program plays out?
Yes, I would say that the smaller the hospital, the more difficult it is perhaps for both patients and colleagues to feel safe reporting. And so we certainly work with a lot of critical access hospitals, but we really have to emphasize that patients have to feel comfortable coming to us, because in a critical access, if you have one surgeon or two surgeons or two hospitalists or something like that, then that might impact, especially colleagues' willingness to go forward. On the other hand, certainly no evidence that the critical access hospitals don't have these problems. Certainly it's a similar issue. We've noticed a physician, for example, having issues at one hospital, he or she quits, goes to another hospital, maybe a smaller hospital in a rural area that we're tracking. For example, we track the Mercy Health System, almost 40 hospitals, rural, mostly in the Midwest. And that same clinician will go to a critical access hospital, but ultimately may be identified again. So without intervention, both critical access and large hospitals seem to have the issues.
Good.
I see
we
one.
Did get okay.
Okay.
No, go ahead.
I'm going to go ahead and read these, Millie. What are the types of disciplinary actions taken? What role for OPP and FPP? So first of all, very important questions. And once again, I forgot to tag my computer. I apologize for this. It's on a quick turnaround here for logging me off. And now I used my So two key things here. Millie, can you hear me?
Yes, I can.
All right. So Percy, two things. First of all, at most of the organizations, the patient complaint monitoring process and the coworker concern at the levels of looking for patterns is protected under peer review. Protected under peer review. So that's most organizations place this right under peer review. However, because of the peer-based, non-punitive nature of this, generally the OPP or FPPE process only starts for that individual if they haven't self-corrected at the persistent pattern level. So cup of coffee not reported to any peer review committee, even awareness evaluations. At Vanderbilt, we don't even tell the department chair if someone has an awareness evaluation, but if the pattern persists, then typically that goes to OPP, FPPE. Below that, there are no disciplinary actions taken for these unless the person has other quality issues. But above that, again, wellness evaluations, coaching, perhaps looking at their patient volume, but the best possible not get into disciplinary actions before the person has a chance to self-correct. From San Antonio, do you have an example of policy you would be willing to share regarding the professionalism pyramid? Yes, I think I can do that. I can at least give you a draft policy. We have a professional conduct policy at Vanderbilt that basically says, have your own cup of, if for behaviors that undermine safety, try to have your own cup of coffee first. If you don't feel comfortable doing that, put in a report, and here's what will happen. So I do need to get approval to send that to you, but Millie, if I can, I'll send that to you.
Okay, great. If you could send it to me, and I'll make sure that it gets out to them.
Okay. All right. Any final questions, either audio or chat room?
I don't see any right now.
Okay. So happy to provide this. Thanks again for all of you for participating. We are at Vanderbilt. Basically, let's see, vanderbilt.edu.cppa, or you can just look up the Vanderbilt Center for Patient and Professional Advocacy. All of our articles and publications are on there, a little bit more about the pyramid, things like that. So thanks so much for attending, and best of luck to work on this at your respective organizations. Have a good day.
All right. Thank you, everyone, for participating, and I appreciate your time and effort. Thank you so much, Dr. Webb, and I'll be closing the meeting now.
Okay. Thank you.
Have a great day.
Mm-hmm.